Welcome back to our second round of presentations in our review course. The presentation will be presented by Dr. Mohamed Al-Fishawi. We have a recording of his presentation, and he will be available 5 minutes after at the end of the session for taking questions. Dr. Mohamed Al-Fishawi, I take this opportunity to present him. He's an assistant professor at the Division of Rheumatic and Autoimmune Diseases in the University of Minnesota, the USA. He's leading the vasculitis clinic there. Dr. Mohamed graduated from the Faculty of Medicine, Cairo University, where he also completed his rheumatology training and his master's degree. He completed his internal medicine residency at Queen's Hospital in New York City, then served as a fellowship in rheumatology as well as vasculitis at the Mayo Clinic, Rochester, Minnesota. He served as member at the ACR Fellows in Training subcommittee in charge of planning sessions for room fellows at the ACR and SOTA meetings, or the state-of-the-art clinical symposium. We are pleased to have his presentation on the topic of aortitis, and we'll start the recording now.
First of all, thank you very much for the committee to give me this kind invitation to present on a topic that is near and dear to my heart, on aortitis, and it's a topic of interest in mine for the past few years, both in clinical and in research arena. I have no financial relationships to disclose, and I will be discussing off-label use and or investigational use in my presentation. And first of all, I would say imagine that you are seeing or evaluating a patient with aortitis. What would be the questions that would be going through your mind when evaluating a patient with that disease? Is it who would be this patient? How does this disease present? What is the workup that I need to do for this disease? And how to treat it? And these will be the questions that we will try to touch on this presentation. So the goals and objectives of this talk is to identify patients with aortitis, the differential diagnosis for aortitis, as well as the treatment options. So the aorta is the major blood vessel that comes out of the heart, and it's the source of nutrition to all the body organs. And then from its branches, blood vessels arise, going to different territories of the body. The aortitis or aortic inflammation can be classified based on pathology as well as based on etiology or the cause. Based on pathology, there are different patterns that can be seen on histopathology, which is either granulomatous, lymphoplasmacytic, mixed, or suppurative. And this is one of the challenges that we encounter when evaluating a patient with aortitis. That first of all, the histopathology is not available in most, if not all, times. The patient has to undergo an aortic surgery or a hemi-arch repair, which, as you can see, a major surgery. And second, that if the histopathology is obtained, there are overlaps, and there are usually lack of granularity to differentiate between the different etiologies. So there could be usually, but not well-deformed granuloma, or sometimes compact well-formed granuloma, or usual well-formed granuloma. Again, depends on the experience of the interpreting pathologist in differentiating between the entities. No clear-cut margins between the different etiologies. And even in patients with reported lymphoplasmacytic pattern, this could represent an undersampled granulomatous aortitis. So moving to the etiologic classification of aortitis. So the first differentiation is it infectious versus non-infectious? And infectious could be either bacterial, viral, fungal mycobacterial infections. And then in non-infections, this could be just limited to the aorta, which is called clinically isolated aortitis, or as a part of a systemic entity, as a part of a wider array of a disease or a syndrome, which we will touch on a case in a case-by-case manner over the next few minutes. So challenges in aortitis. We touched on the difficulty in getting a tissue diagnosis. And most of the time, if not all the time, there is no specific symptom related to aortitis, but there definitely would be some sort of systemic symptoms. So this would be fevers, night sweats, loss of weight, loss of appetite. However, no focal symptoms that would pinpoint us towards aortic inflammation. And there is no special directed therapy unless this is a part of a systemic disease with a known or a defined treatment. And then we will start with the first entity, which is isolated aortitis. So this is inflammation that is limited to the aorta. And for that, we did a chart review study from Olmsted County, Minnesota, using CPT codes for patients who underwent ascending aortic aneurysm to further study the epidemiology of this entity. And we looked at histopathologically confirmed aortitis in the absence of any infection, rheumatic disease, or systemic vasculitis. And over the span of 21 years, we only identified 8 incident cases. The majority were females, they were older, and they were diagnosed, of course, after having an ascending aortic aneurysm repair. And the annual incidence rate is 8.9 per million. So this is a quite rare disease. And as you can see, the demographics of this patient category overlaps with giant cell arteritis, as we will touch on later. Some experts say that this is a truly isolated entity. Some experts say that this could be a form on the spectrum of giant cell arteritis. And then we start with a case. So this is a 70-year-old female with fever, fatigue for 4 months, and was undergoing evaluation for an infection malignancy that has been non-revealing. Came presented to us in the clinic. She didn't have any cranial symptoms, so no headaches, jaw pain, scalp tenderness, symptoms, visual symptoms that would be indicative of a cranial giant cell arteritis. She did not have any past medical history, and she had significantly elevated inflammatory markers. And in this situation, the test that we usually go to is the PET scan. And as you can see on the left side of the screen, there is significant uptake throughout the aorta and throughout the subclavian, axillary, and the distal part of the aorta going into the lower extremities. On the right side of the screen, the top part, there is uptake in the subclavian and axillary arteries, and in the bottom right, this is uptake in the ascending aorta as well as the descending thoracic aorta. So this patient has giant cell arteritis, the large vessel variant. She was started on prednisone 60 milligram as well as steroid-sparing agent to inflammation. And if it happens, where would that be? And will it shorten my life? And what would be the treatment? And then the usual question that we get from patients, are you sure? And what else can cause that? So what is giant cell arteritis? This is the most common form of systemic vasculitis above the age of 50, with an annual incidence in 1 in 5,000 above 50 years of age, with a lifetime risk of 1% in women and half in men. And it's more commonly seen in patients from Northern European ancestry. And in our cohort in the Midwest, it's 75% is females, and average age of onset is 77 years. So disease of the elder population. Presentations varies from one population to the other, but from our cohort, 71% of the patients had a headache. Half of the patients had scalp tenderness or jaw claudication, and a smaller percentage had visual symptoms or polymyalgia rheumatica. In a systematic review of 14,000 patients, jaw claudication had the highest likelihood ratio for positive temporal artery biopsy. And the way that we describe jaw claudication, so this is an ischemic pain of the muscles of mastication. So patients will have pain with chewing food, and the pain would stop after stopping the activity and then would recur on a consistent manner. So I usually tell our residents and fellows that think of it as the peripheral arterial disease of the jaw. So more recent advances have led us to better understanding of giant cell arteritis, that there are several subtypes where there is cranial giant cell arteritis limited to the head and neck area, which is about 33%. And then there is cranial and large vessel disease, which is about 55%. And there is only limited large vessel disease. And typically these patients will not have any cranial symptoms. So they are not going to have headache, jaw pain, scalp tenderness, the usual symptoms. They will only have aortitis and systemic inflammation. And what we know so far on the pathogenesis of GCA, that there is dendritic and T cell activation with a heightened inflammatory milieu with IL-6, GM-CSF, and IL-17. We know that the dendritic cells have low expression of PD-L1, and ultimately there is activation of the myofibroblast, leading to vascular remodeling, intimal hyperplasia, then vascular occlusion, and thus there is ischemia and subsequent tissue. So back to our patient, to answer a question about the aneurysm, will she get it? Where would she get it? And would that affect her life? So we studied a retrospective chart review for all incident patients with giant cell arteritis from 1950 to 2016, population-based cohort from Olmsted County, Minnesota. So for those not familiar with the Olmsted registry, so this is Olmsted County, Minnesota, where there is Mayo Clinic, Olmsted Medical Center, and other private practitioners within the area are linked through the Rochester Epidemiology Project. So this gives you virtually access to almost all the records for the patients living in the county, whether it's inpatient, outpatient. So it makes it very suitable for population-based research. So we looked at incident aortic events, large vessel disease 1 year prior, and then thereafter on follow-up after diagnosis of giant cell arteritis. And then because the cohort spanned more than 60 years, we divided it into three parts. The part from 1950 to 1975, 75 to 1999, and then from 2000 to 2016. So this would be more contemporary and also after our understanding of the disease over the several decades. And in order to ascertain the risk of aortitis, we assembled a comparator cohort from the same population, and we matched it to the incident cohort from 2000 to 2016. So we identified 289 patients. The majority were females. Temporal artery biopsy was positive in about 81% of the patients. And when we looked at incident data, if you look at, so these are the three cohorts, the oldest cohort, and then from 75 to 1999, and from 2000 to 2016, and the blue line. So if we follow patients for 5 years, so about 27.8% will develop a large vessel event. And if you follow patients for 15 years, and mostly in the most contemporary cohort, 49.2% will develop a large vessel incident. If we hone in into aortic events, either aortic aneurysm or dissection, the incidence rate is about 19%. So this means that about 1/5 of the patients will develop an aortic event, whether aortic aneurysm or dissection, if you follow them long enough for 15 years. And then looking at the GCA cohort versus the comparator. So we have proven as well that the giant cell arteritis is a risk factor for development of large vessel disease. And the risk for aortic aneurysm is 19% in this population as opposed to 5.2%, or these are the incidence rates for aortic events. So again, this helped to answer the question because clinicians were asking, maybe what we're seeing is aortic events is just limited to atherosclerosis. These are elder population, have comorbidities that predispose them to vascular disease. But indeed, we were able to prove that giant cell arteritis is a risk factor for these events. And looking more granularity on the aortic data, so 16 patients with GCA had an aortic event versus 6 in the non-GCA. And thoracic aortic aneurysm stood out in 15 patients with GCA as opposed to only 1 patient in the non-GCA, where abdominal aortic aneurysm percentage-wise were more commonly seen in non-GCA. And from that, we calculated the risk, and indeed, large vessel giant cell arteritis is a risk factor for large vessel disease, whether it's a stenosis or aneurysm, and specifically in aneurysms will be in the thoracic region of the aorta. And when we looked at mortality, we found that patients with giant cell arteritis and large vessel disease are at high risk for mortality, and that is specifically higher for those who have aortic events, either aneurysm or dissection, and the cause of death would be from cardiovascular disease. But when we looked at the mortality trends, we found that there is improvement or decrease and decrease in mortality rate in the most recent cohort as compared to historically. So this translates to better understanding of the disease, better understanding and control of risk factors. So clinicians are getting to understand the disease and helping patients more. So to answer the patient's question, yes, there will be a risk for aortitis and aneurysm, and if it happens, most commonly will happen in the thoracic aorta, and about the lifespan, unfortunately, having an aneurysm will shorten the lifespan, but we are getting to get better than previous years. And then when we were doing the study, we encountered patients who underwent surgery for aortic aneurysm. So these are patients who are being evaluated, monitored, and treated, and despite that, they developed aneurysms still, and they underwent surgery, and lo and behold, 66% of the patients on treatment had active inflammation on histopathology, including a patient with carotid artery surgery. So that led us to study this in depth. So we did a retrospective study for patients who underwent thoracic surgery. From 2000 to 2021, we identified 4,600 patients, 49 of them had giant cell arteritis before the diagnosis or before surgery for a thoracic aorta. 78% of that had positive biopsy, and the time interval between the diagnosis and surgery at a median of 5.6 years. So again, these are patients later in their disease process. All of the patients were in clinical remission by the time they had surgery. The mean prednisone dose was almost 10 milligram, and about 39% were on immunosuppressives. We pulled in the pathology slides that were available for these patients, and we had them reviewed by an expert pathologist in cardiovascular diseases. And we identified 43 patients, available slides, and in 82% of these patients that were in clinical remission, there was active aortitis on histopathology. 10% had healed aortitis, and 8% had no active or healed aortitis. There was no difference between the groups, and there was no difference in the inflammatory markers. So the striking findings led us to the thought that this is just the tip of the iceberg. We are managing patients clinically, biochemically, but there is definitely changes that is ongoing in the tissue that we're not aware of. But most of these patients were on prednisone. Now we have better treatment options within the biologic arena. And this is mainly the treatment now that we go to is tocilizumab. That's based on the JACTA trial, which is tocilizumab for giant cell arteritis and its extension phase. So in this trial, 4 arms, patients were randomized into either tocilizumab weekly and a 26-pret taper, or tocilizumab every other week with a 26-pret taper, or placebo and 26-pret taper, or prednisone for a 52-week taper. The original study was for a year, and then the extension phase was for 2 years. And the study reported that in the first year, on the weekly tocilizumab group, 56% of the patient had sustained remission, as opposed to in the 52-week prednisone taper, there was only 18%. So this is the red bar. Then on the 26 prednisone taper, this is only 14% of patients had sustained remission. And that led the FDA to have regulatory approval for tocilizumab as the first biologic, as the steroid-sparing agent for active giant cell arteritis. From the extension phase, we know that only 24% of the patients remained in sustained remission, as opposed to 12 and 10% in the prednisone group. But with the help of a little bit of prednisone beyond the protocol in the first year at least, we were able to achieve remission in about 95% of the patients with tocilizumab. So how about adverse events? So in the first year of the trial, there was one patient on the every other week that developed anterior ischemic optic neuropathy, and that was treated with steroids. But in the extension phase, there was one patient that had aortic dissection, one had aortic aneurysm rupture, and one had GI perforation. So that again gives us an idea that aortic events, aortitis, dissection, aneurysm, are a late complication of this disease rather than an early complication. So this is basically what I tell patients when I see them in clinic, that I would recommend tocilizumab. I recommend it in the weekly dosing, and 56% of the patients who did that had remission, has disease under control, and within the protocolized prednisone. If you flare 95 and we treat you with prednisone, then 95% of the patients with this scenario will end up being in remission under control. How about if we stop it after a year? Then there is a 42% of the patients will stay in remission. So it's more like a 50-50 chance. But if we restart the prednisone after stoppage, 95% of the patients will be in remission. So very good results in case if patients opt to stop the tocilizumab after 1 year. But there are other options that are available. So this is the EGYSIR trial that was recently published this year, which is the upadacitinib for patients with giant cell arteritis. 3 arms, upadacitinib 15 milligram, 7.5, and a 52-week pred taper, and comparable results. So 46.4% of the patients of the upadacitinib 15 milligram had sustained remission in a year, versus 29% in prednisone 52-week taper. And as you can see, these are comparable results to the DIACTA trial, and that what led to the regulatory approval for upadacitinib as the second steroid-sparing agent for patients with giant cell arteritis. It is interesting that patients in the 52 pred taper in the upadacitinib trial had higher percentage of remissions. This is mainly due to the selection of the patients that the investigators had, but this might have blunted some of the secondary outcomes in the upadacitinib trial. Other medications that are currently out there that's being tested, which is magrolimab, which is a GM-CSF antagonist, subcutaneous injection against placebo, a shorter trial, but had some good results, significantly increased percentage of patients with remission as opposed to placebo. Another agent was secukinumab, similar outline, secukinumab versus placebo, and higher percentage of sustained remission, although there is some reports that in the extension phase, some of the outcomes of the study has not been met. We're waiting for the full publication of the manuscript. So back to the patient, when she said, "Are you sure of the diagnosis? What else can cause these symptoms, or mainly aortitis?" And with that, we will touch on the rest of the etiologies of aortitis. So this is another patient that was referred to as a 23-year-old Crohn's disease at the age of 16, treated historically with prednisone, azathioprine, and adalimumab, had headache, hypertension, and a very low systolic murmur in the chest. Inflammatory markers were elevated, and then imaging revealed aortitis and significant large vessel vasculitis. So inflammation in the carotids, subclavian, celiac, abdominal aorta, and the renal vessels. So this patient was diagnosed as Takayasu arteritis with inflammatory bowel disease. We ultimately treated her with prednisone cyclophosphamide induction for 6 months and then switched to upadacitinib. So kind of hitting two birds with one stone. Upadacitinib would help with her inflammatory bowel disease as well as the large vessel disease. And there is ongoing now SELECT-TAC trial, and results hopefully will be out in a few years. So this is a study in upadacitinib in Takayasu arteritis, mirroring the SELECT-GCA trial that we just touched on. So Takayasu is a rare disease with a prevalence of 8 cases per million. It's more seen in females compared to males. Usually non-specific symptoms, but some patients will have headaches or choroidinia. They will have absent pulse and hypertension. Challenging disease to diagnose and manage. Usually it's delayed in diagnosis with a median of 17.5 months, and survival is decreased with, in 15 years, only 86% of patients. And these are very young patients with a high standardized mortality ratio of 3, and more than half of patients will undergo surgery. Steroids remain to be the major medicine that we use, and usually we use it in combination with DMARDs as well as biologics. And then the third case is an 83-year-old male with abdominal aortic aneurysm, underwent EVAR 15 years before presentation, referred to us for abdominal pain and loss of weight, significantly elevated inflammatory markers, and he had enlargement of the abdominal aortic aneurysm with peri-aortic stranding. So, and this was on a conventional CT scan. And usually in these situations, I refer to the PET scan, because PET scan, not only it shows us the anatomy, it also gives us an idea about activity of the disease and the site of activity. And as you can see here in the picture, there is significant uptake within the stent, the aortic stent. And that gives us an idea that the inflammation is most likely driven by the stent. And there was a high index of suspicion in this case that this is an infection, an infected stent that is leading to the peri-aortic stranding. So standard blood cultures were negative, and because of the heightened index of suspicion, and in collaboration with our colleagues in infectious disease, we went ahead and did metagenomic sequencing from the bloodstream for infections, and that identified Klebsiella pneumoniae. And ultimately, the patient was placed on antibiotics, and he was diagnosed with infected aortic stent. Of course, it was he was using levofloxacin, which we would be monitoring closely, because it has been identified that one of the antibiotics that can cause vascular events and can cause weakness in the vascular walls. But this went well for this patient, and he got better afterwards. So then the next patient is a 49-year-old female with HIV and 12 years of pulmonary sarcoidosis, and she was off treatment. Presented to us with chest pain, elevated inflammatory markers, and elevated troponin. And then on the reconstructed images from her CT coronary angiogram, you can see there is a thickening in the left anterior descending and right coronary artery, as well as the aorta. And then there is a selective FDG uptake within the LID on a PET scan. So this patient had sarcoidosis along with vasculitis, aortitis, coronary periarteritis. And one of my colleagues actually looked into the vasculitis in patients with sarcoidosis. And over about 20 years, identified 17 patients. They were split even, so 9 patients had large and medium vessel disease, and 8 patients had small vessel disease. 3 patients had aortic events. Sarcoidosis preceded the vasculitis, and about 44% in the large and medium category, and about 38% in the small vessel category. And as you would notice, that patients with large and medium vessel disease, they had more aggressive treatment with at least one DMARD or biologic, but there was favorable outcome for both categories. So this is sarcoidosis with secondary vasculitis. And then we go into the next case, which is a 57-year-old with weight loss, diarrhea, headache, and intermittent vision loss. Was initially felt to have giant cell arteritis. However, he had some features that didn't usually fit with giant cell arteritis. Elevated inflammatory markers and elevated serum IgG4 levels. So we got a PET scan for this patient and showed aortitis with ascending aortic aneurysm, as well as coronary periarteritis and lymphadenopathy. Ultimately, lymph node evaluation showed elevated IgG4 to IgG ratio, and actually with a staining for his temporal artery biopsy, and this showed also increased IgG4 to IgG ratio. So he had IgG4-related disease vasculitis with temporal arteritis, coronary arteritis, aortitis from IgG4-related disease. So IgG4-related disease is a form of variable vessel vasculitis. It can cause aortitis, periaortitis, as well as other form of vasculitis. And in histopathology, you can see storiform fibrosis, lymphoid follicle formation, and obliterative phlebitis. Treatment is prednisone and DMARDs and a B-cell depleting therapy. And recently, there is a FDA-approved monoclonal antibody, inebilizumab, or targets the CD19 on B cells. It has been FDA approved for a few years for NMO, but recently got approval for IgG4-related disease as well. And then the next etiology, based on this case, this is a 67-year-old male with comorbid conditions, hypertension, hyperlipidemia, chronic kidney disease with biopsy showing diabetic nephropathy, had obstructive uropathy, stent placement, elevated inflammatory markers, and was referred to us for diagnosis of retroperitoneal fibrosis. He was initially treated with prednisone and mycophenolate. However, he started to get complications from the treatment, admitted with DK, and then afterwards fluid overload. And then we got a PET scan for this patient that is depicted on the right. And for those of us who see these diseases in those patients, there is something atypical within the scan. There is, as reported, intense uptake, perirenal and pararenal, and there is hazy uptake within the aorta and the ureters. This is beyond the usual periaortitis. So that stood out to us when we were evaluating the patient. The biopsy that was obtained initially showed chronic fibroinflammatory mass. Patient started having complications with fluid overload, so we tapered his prednisone. Initially, he was treated with rituximab for an episode of pericarditis. So again, these are things that does not fit quite well with periaortitis or retroperitoneal fibrosis. So we ended up doing a rebiopsy of the fibroinflammatory tissue, and then we sent it for BRAF V600E. And that came back as negative, but because of the heightened suspicion, we did next generation sequencing. It was positive for mutation in MAP2K1, and this patient ended up with Erdheim-Chester disease, which is a histiocytic disease that can cause periaortitis. And what we saw on the PET scan, this is what we call hairy kidneys. He was treated ultimately with gubimatinib, which is a targeted therapy. And then the next patient is a 20-year-old female with P-ANCA with glomerulonephritis, inflammatory eye disease, and airway disease, treated with cyclophosphamide, rituximab, Imuran, and was off therapy. Presented to the hospital with headache, found to have subarachnoid hemorrhage, as well as intracranial vasculitis and aortitis. So this is a patient with a small vessel vasculitis that now has changed its presentation to a large vessel vasculitis. We treated her with corticosteroid, rituximab, and the avacopan, which is a C5a inhibitor, complement inhibitor. And then she ultimately went into clinical remission. And that led us to study patients with small vessel vasculitis who do develop large vessel disease. And we looked at patients with ANCA vasculitis from 2000 to 2021. And then we identified 36 patients from a 3,700 patients using ICD code search. And they had either arteritis of the temporal artery, aortitis, or peri-aortitis. And as you can see in the diagram, patients could have arteritis of the temporal artery even prior to the diagnosis of ANCA vasculitis, or they could have aortitis concomitantly with the diagnosis of ANCA or after, or they could have peri-aortitis before the diagnosis of ANCA vasculitis. And if you follow the patients long enough, then they develop features suggestive of ANCA-associated vasculitis. Most of these patients were treated with glucocorticoids, rituximab, or methotrexate, and patients who died during follow-up, there was no difference between that cohort compared to the general population. So it's not a form of an increased risk of mortality compared to the general population. And then the last two cases to touch on is a patient with metaplastic carcinoma, adenocarcinoma of the breast, was treated with pembrolizumab, which is an immune checkpoint inhibitor, paclitaxel and cyclophosphamide, developed fevers and chest pain 11 days after filgrastim, which is a GM-CSF agonist. And she was hospitalized for fever of unknown origin, and diagnostic workup was negative. 2 months later, presented with similar symptoms. And as you can see in this PET scan, there is significant uptake in the ascending aorta as well as the descending thoracic aorta. And along with that, there was actually another patient that was referred to us from oncology for recurrent metastatic serous ovarian cancer. And 7 days after pegfilgrastim, developed similar symptoms with elevated inflammatory markers. And on the left side is the scan prior to administration of pegfilgrastim, and on the right side, there is significant thickening within the arch vessel as well as the aortic arch. So these patients have drug-induced aortitis, and there is an entity now that's being recognized, which is immune checkpoint mediated aortitis. And the French group has described this in patients who receive PD-1, PD-L1, as well as CTLA-4 inhibitor therapy. They studied patients from 2018 to 2024 and identified 27 patients. Some of them present as if it's a true PMR-GCA. And there were 4 patients in this cohort that developed visual loss, and 56 of the patients had aortic inflammation. And mortality was 33%, and that this was mostly attributable to the cancer. And in their pegfilgrastim or GCSF, there can also induce aortitis. It's a rare entity, about 50 cases in literature. There's a big study coming in out of Japan of 18 patients out of 600 patients who received GM-CSF. And it's seen more with pegylated filgrastim as opposed to filgrastim. And that rings a bell to one of the earlier studies, the earlier slides, when we talked about the pathogenesis of giant cell arteritis, where there is heightened GCSF. So if you give a GCSF analog, then it makes sense that this will develop a form of synthetic or chemically induced aortitis. So that's why we prefer in patients specifically with neutropenia that, and if there is an underlying autoimmunity, that to be cautious with prescription of filgrastim or pegfilgrastim because of the side effects of this disease. Treatment is usually prednisone. Sometimes, in some occasions, we tend to use a steroid-sparing agent. So this is the PET scan from the earlier patient, pre and post. That patient ended up treating her with prednisone and tocilizumab because she received both GM-CSF and pembrolizumab. And then the other patient, because she was enrolled in a clinical trial, she had serial CT imaging. And as you can track, this is the CT scan at onset on the top right, and then follow-up CT scans within about 1 to 2 month interval showed complete resolution of aortitis with steroids. So to summarize, aortitis is a disease of inflammation in the aorta. This could be either isolated, which is clinically isolated aortitis, or secondary to a systemic disease. Infections and medication-induced aortitis is an important entity and has to have to be considered. Biopsy is not usually available in patients and even needs expertise in interpretation. PET scan is a modality that is very helpful and can provide information on the level of activity and the site of activity, and can also help in diagnosis confounders, as we saw in patients with Erdheim-Chester. Corticosteroids are the first-line therapy, but additional therapy is usually needed. Agents are used for giant cell arteritis now, or tocilizumab and upadacitinib. Upadacitinib can also be used for Takayasu arteritis, and there is FDA-approved treatment for IgG4-related disease called inebilizumab. And with that, I will thank you for your attention, and I'm happy to answer any questions that arise. Thank you.
Thank you, Dr. Fishawi. We are running short of time, so we can cautiously take one question, one very short question, if anyone has a question. If not, we thank Dr. El-Fishawi and we move to the next presentation. Now we have Dr. Marcella Vicentini. Is she online?
Yes.
Yeah, how are you, Marcella?
I'm fine, thank you.
Thank you. Thank you for accepting our invitation and presenting your interesting topic. Although we'll have to offer a round of coffee to clear our minds for your difficult subject. Okay, Dr. Marcella Vicentini is Associate Professor, the Department of Translational and Precision Medicine at Sapienza University of Rome, Italy. Also, she is the director of the Postgraduate School in Allergy and Clinical Immunology. She is a specialist in internal medicine with a PhD in immunological sciences, serving as attending physician at Policlinico Umberto I of Rome. Her work focuses on B-cell subpopulations, particularly CD21, marginal zone B cells, HCV-related lymphoproliferative disorders, and I would say here that we shared our study on the relapse of HCV cryoglobulinemia following sustained viral response, thanks to her contribution and other centers. She conducted research at leading international institutions and also over 90 publications in high impact factor journals. Dr. Vicentini, we are all anxious to listen to your topic.
Okay.
Okay,
Thank
on
you.
the new subset of B cell.
Okay, thank you.
Okay, the stage is yours.
Thank you. Thank you for this introduction. Can you hear me?
I can hear you clearly.
Yes? Okay, so I share my screen.
Yes, we have it now.
Okay. Just 1 second. Okay, yes, here we are. So again, thank you for this kind invitation. I'm very happy to be here and to share some very interesting data about this particular B cell population that has gained in the last year more and more interest, in particular in the autoimmunity world. So I start with this presentation. So does not work. Okay. So I start with looking at human B cell development, so we can also localize our new B cell subset. So here in this very nice picture, you can see the B cell development in all the different stages. And here in the bone marrow, pro B cell differentiate to immature B cells, where they exit from the bone marrow equipped with a functional B cell receptor, differentiate in transitional B cells, and then in naive B cells. Naive B cells can start the germinal center reaction in the secondary lymphoid organs, and can encounter the antigen with the help of T cells. Here in the germinal center, they start with the dark, in the dark zone, the B cells proliferate, and then in the light zone, they usually undergo somatic hypermutation to mature their affinity of the B cell receptor and to undergo isotype switching. So the B cells express an IgG or an IgE or an IgA instead of their IgM and IgD. And then they exit from the germinal center, usually as memory B cells here, that can differentiate in short-lived plasma cells or in long-lived plasma cells that are responsible for the long-lived humoral immunity. A very interesting zone that around the germinal center is the marginal zone. Here we can find marginal zone B cells, usually expressing CD27, IgM, and IgD. And these are a sort of B cells as a bridge through the innate and adaptive immunity, because they are able to produce the so-called natural antibodies, which are polyspecific IgM and are ready. So they respond to blood-borne antigen usually. But as we can see here, resting naive B cells can undergo an extrafollicular pathway, and with the help of T cells differentiate in activated naive B cells without entering the germinal center, and differentiate in double negative B cells that usually do not express the CD27 and the IgD. And this can give rise to short-lived plasma cells without entering the germinal center. And this is the population we will focus on. So we here again the same concept about B cell development with a particular focus on the markers expressed by the different B cell subpopulation. So we know that naive B cells express IgM or IgD as B cell receptors, and memory B cells are characterized by the expression of the CD27 and IgM, IgD for marginal zone B cells or unswitched memory B cells, and then IgG, IgA, or GE if they underwent isotype switching. Plasmablasts and plasma cells usually express CD38, and the extrafollicular B cell response here we have B cells that differentiate without the germinal center reaction in plasma cells. And again, here, our population of interest that we think it is generated from naive B cells under particular circumstances, and differentiate in double negative 1 and 2, characterized by the expression of the TBET, transcription factor TBET, and CD11C. And now we will go more in detail on this particular B cell subpopulation. This subpopulation has a quite short story. It has been described for the first time about 25 years ago from the group from Anthony Fauci and Susan Moyer. They described in HIV patients the expansion of this particular B cell population, characterized by the absence of CD27 and the low expression of the CD21. And they were actually memory B cell and resembled in some way tissue-like memory B cells, so a sort of B cell that were described described in the human tonsil and expressed a particular inhibitory receptor that is called the FC receptor like 4. Later, a group from German, the Klaus Warnat's group, they described the same cells, quite the same cells, in immunodeficiency that is called common variable immunodeficiency. Later, we, together with other group in France, described the same population in a chronic hepatitis C virus patient, and we termed these cells as anergic exhausted B cells because of their functional and phenotypical characteristics. Then in 2011, the same cells were termed age-associated B cells, and this because these cells were described in aged female mice and again with the same phenotypical characteristic. Same cells in malaria patients in 2012 and called atypical B cells because of their strange phenotypical characteristics. In 2018, in lupus erythematosus, these cells were described as double negative B cells. Again, as said before, because of the absence of the CD27 and the absence of the IgD, again with the same phenotype. Now, later on, these cells have been found in other autoimmune diseases, and therefore some groups term these cells as autoimmune-associated B cells. But this led to, all this information led to the identification of different yet overlapping subset of Tibet high CD21 low B cells. And this different nomenclatures and the different groups working on these the same cells created a little bit of confusion. In summary, this particular B cell population, which is found in all these different disorders, is actually characterized by the positivity for the transcription factor T box that is usually expressed in T cells. And in T cells, Tbet has the role as a regulator of interferon gamma production and Th1 sulfate. In B cells, actually the function is not completely clear. It has been shown that it has a role in the isotype switching in IgG2A. Then these cells have express the CD11C, which is usually a marker of dendritic cells, which is an integrin alpha X chain, and they have a low expression of the CD21, which usually characterize follicular B cells and B cells in general. CD21 usually forms a complex together with the CD19 and with the CD81 and function as a co-receptor to the B cell receptor. Indeed, upon the simultaneous binding of complement-tagged antigens by CD21 and the B cell receptor, the threshold for B cell activation is reduced, and our cells express very low amount of this CD21. So, while some of the definition of all this of the same B cell subset reflect different names of overlapping phenotypes within the same population, it is quite clear that that different stages of Tibet positive CD21 low B cells exist, depending on the expression of the CD27 and the BCR isotype. So we can find activated naive B cells that express IgM, IgD, and do not express the CD27. The same for the double negative B cells that express IgG and IgA. So they underwent isotype switching but do not express CD27. And then we have memory, activated memory that express the CD27 marker. So the group from Germany, which which studies really in depth these cells since a long time, they've made a very nice work some years ago because they analyzed these cells in different diseases. So in rheumatoid arthritis, in lupus erythematosus, and in immunodeficiency, and they found that these cells expanded in different disorders actually have similar characteristics. Indeed, they express the CD11C. Here, these dots represent all the diseases that I mentioned, so rheumatoid arthritis, lupus, Sjogren, and they have the expression of CD10, CD38, CD32, the inhibitory receptor FC receptor like 4, FAS, and they have a low expression, as shown here, of the CD62 ligand, which has a role in the migration of these cells. And talking about migration, these cells have a particular pattern of chemokine receptors. Indeed, they have high expression of the CXCR3 and the CXCR6, which favors the migration towards sites of inflammation and extralymphatic sites. Indeed, here we find a joint, and in rheumatoid arthritis, these cells have been found increased here. Whereas they have a low expression of the CXCR4 and CXCR5, which favor the migration to bone marrow, spleen, and lymph nodes. And here, indeed, in this nice cartoon, we see how these cells have been described in chronically activated inflamed tissue, starting from the lung of the severely ill common variable immunodeficiency patients, in the joints, in the kidney of lupus patient, in the gut of Crohn's disease, and in the salivary gland of Sjogren's syndrome, and again here even in the obese in the adipose tissues of the obese patients, whereas low amount of cells are found in the blood and in the some secondary lymphoid organ of the healthy donors. And when looking at their functional properties, here again a nice table showing the results of different studies that analyze these cells again in different disorders, and where we see that these cells have a low proliferative response after stimulation with the BCR, with anti-Ig, with the T cell help, and with the stimulation of toll-like receptor 9 or 7 with the CpG or R848. So less proliferative capacity of these cells. And this goes together with a reduced BCR-dependent signaling in these cells upon BCR stimulation, both at the beginning of the signaling pathway as at the end of the BCR signaling. And this group looked at the transcriptional profile in CD21 low B cells, again in different disorders, concluding that these cells have a shared transcriptional profile that in part here for the cell surface markers resembles the findings with the phenotypical analysis. We have an increased expression of activation markers, CD86, expression of the FAS CD95 for CD11C, and even the transcription factors have, which again in red, the higher transcription factors, the higher expression of some transcription factors, again like Tibet, ZEB, which now is very studied, and for cytokine and signaling. So these cells are similar in different disorders. And all this data that we obtain from these studies help us to understand how these cells originate and are generated from and maintained. So factors that seems to be involved in the differentiation from classical Tibet negative CD21 high B cells into our particular subset include the interferon gamma, the IL-21, together with the triggering of the CD40. And all this signal can be provided by T follicular helper cells, and has been shown even that the canonical NFKB signal is crucial for the differentiation, and the role of toll-like receptor 7, 8, and 9 seems to be implicated in particular in the autoimmune setting. So now let's have a look where we can find these cells and if they might have a pathogenic role in the development of the disease. As said, we can find these cells in a chronic infection, so hepatitis C virus, HIV, and malaria. And what is in common in these infectious disease is that these are chronic pathogen infections that are associated with impaired B-cell mediated host defense. And we found some years ago that in hepatitis C virus associated mixed cryoglobulinemia, which is an autoimmune and lymphoproliferative disorder, there is an increase in these cells, as you can see here in this cytophotometric analysis. We have a CD21 low, CD11C positive B cells that, when stimulated with CpG and anti-BCR, here the first row indicate our CD21 low B cells. We have a reduced proliferative capacity as shown by the decay of the CFCE compared to the normal counterpart that, as you can see, proliferate much more. And in this context, we hypothesized that this low proliferative capacity and this exhausted phenotype in part could be an homeostatic mechanism to dampen the lymphoproliferation that is often seen and complicated mixed cryoglobulinemia, so a sort of defense to avoid the lymphoproliferation. Then we have these cells in malaria and in HIV, and in both situations, the expansion of the CD21 low Tibet positive B cells is usually associated with the acute phase of the infection, and in particular, in both situations, these cells are enriched in antigen-specific antibodies against malaria and against HIV. And in patients that are under treatment, in particular in HIV patients, these cells reduce in frequency and are not more found in the peripheral blood. So they clearly correlate with the acute infection phase. Then we find these cells, as said, in common variable immunodeficiency, which is a primary immunodeficiency disorder characterized by the absence of the capacity to produce immunoglobulin, IgG, IgA, or IgM, and these patients suffer from a recurrent infection, usually respiratory and gastrointestinal infection, but they also, a subgroup of patients with this disease, usually suffer from autoimmune and or granulomatous diseases in the lung, and in this subset, CD21 low Tibet positive B cells are usually significantly expanded. And here on the right, a list of inborn error of immunity, where you have the mutation of a particular molecule that is responsible for an immunodeficiency, and in these situations CD21 low B cells have been found, and the single mutation helps even to understand if some pathway are involved in the generation and maintenance of these cells. And we, together with a group in Germany, we described these cells in the 2009, and we found that these cells were in common variable immunodeficiency patients were indeed enriched in the broncholavage of these patients, and describe this here. in these patients. And we found also that phosphor-ERK was reduced upon stimulation of the B-cell receptor, as said before, giving a sort of anergic phenotype of these cells in common variable immunodeficiency. And what about autoimmunity? So it has been shown again. We in Sweden, there is we showed that these cells are expanded in patients with rheumatoid arthritis, and these cells are found in the inflamed tissue of this patient. Then we found an increased percentage of CD21 low B cells in the systemic sclerosis patients, suggesting even that these cells act as possible marker of vascular complication or even of new digital ulcers in these patients. CD21 low B cells are found also in Sjogren's syndrome, and they are associated with more increased risk of lymphoproliferation. And then great interest in these cells comes from the group, from the our neurological patients affected by multiple sclerosis. Here, CD21 low are increased and found in the liquor of these patients. But what about systemic lupus erythematosus? Here, these cells are studied in depth. The interest of a particular B cell subpopulation started long time ago about double negative B cells, as said before. B cells that do not express the CD27 and do not express the IgD. And based on other markers like CD11C, the chemokine receptor EGYSIR5, and the TBET, these cells are further classified in 4 subgroups. But double negative 2 B cells are our cells. Indeed, they express the CD11C. They do not express the EGYSIR5 that favors the homing in lymphoid tissue set, and they express TBET and are significantly expanded in lupus patients. Here, indeed, this group in 2018 published in Nature Communication that these cells are increased in lupus patient and in lupus patient with active disease. And moreover, they also showed that in some acute manifestations, these cells are significantly increased, like in active nephritis, in malar rash, and so they correlate with the disease activity. And they also found, as we said before, that these cells are found in the kidney tissue of these patients. And here, in the same paper, they also made a very interesting experiments. They sorted B cells from lupus patients, so naive B cells, memory B cells, and our CD11C, CD21 low B cells, and they cultured these cells with anti-CD3 activated T cells, and after 7 and 11 days, they analyzed the supernatant of the cultures to analyze the production of autoantibodies. And as you can see here, autoantibodies were found enriched in the cultures of the CD11C positive cells, which are here shown in red, though these cells produce pathogen autoantibodies. And we also contributed to the research of these cells in lupus patients. Indeed, here we showed that in lupus patients, TBET positive B cells are increased compared to the healthy donors and compared to lupus patient in remission. And we also showed here in this last data, we showed that those patients that have a TBET high phenotype, they have a completely different, completely, not so completely, but they have a different B cell distribution with the reduced naive B cells and increased switched memory B cells. And then we also showed that those patients in whom the Tibet B cells rapidly reduce after belimumab treatment were those responding more to the treatment, so suggesting a role as predictors of response of these cells. And so, in conclusion, for this first part of my presentation, we can say that CD21 low, CD11C Tibet positive B cells are found in autoimmune diseases, and they have a role in autoantibody production, and they have a role as for cytokine secretion as antigen presenting cell in all these autoimmune diseases. And the question is whether these cells are therefore friend or foe, because they produce autoantibodies and they act as antigen presenting cell in our autoimmune diseases, but they are also enriched in antibodies against our pathogen during infections. And again, seeing these cells as possible friend, a very nice paper from 2023 showed that the CD11C B cells are enriched in vaccine antigen-specific B cell compartment in the healthy donors upon vaccination, offering therefore a very important strategy in vaccination, in vaccinology. And then talking about health condition, we also it was also shown that CD21 low, CD11C B cells are found, as I said at the beginning of my presentation, are found in aged female mice, and later on, therefore, these cells were defined as age-associated B cells. And later on, these cells have clearly shown to contribute to inflammaging and to all these immunological features that we see in aging, like damped B cell genesis, altered immune response to both primary and recall antigens. And in the spleen of murine, it has been shown that with the age, the splenic B cell pool is in part replenished with this particular B cell subset. And now, after all this information about these cells, and as said, these cells have more and more gained more and more interest in the scientific world, in particular in the autoimmunity diseases. Obviously, the question is: can we, in some way, target these cells, or are these cells in some way targeted by our B cell depletion treatment or by other treatment that we use in all these diseases that I mentioned? Well, here we see again the B cell development in the bone marrow, and this follows defined stages that are usually, as we saw before, these changes are goes in parallel with the surface marker expression that are usually susceptible to different target therapeutical strategies. And so the very beginning phase of the B cell development in the bone marrow, we have the pro-B and the pre-B that express the CD19, whereas the CD20 is expressed later on. And so these cells are less susceptible to rituximab, which usually targets the CD20. And 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 going on with the B cell development, we see here that the transitional and the naive stage, these cells rely most on BAF signaling. So treatment that target BAF, like belimumab, acts more on these cells, whereas when the differentiation undergoes to plasmablast and plasma cells, again, here we have a reduced expression of the CD20, and we know that rituximab does not target these cells because of the absent expression of CD20, whereas CD19 is still expressed on short-lived plasma cells. And that also express the CD38, the daratumumab, which is also expressed in other cells. And here other targets that are now F7 is now tried in myeloma, multiple myeloma, and all these question marks are here to show and to ask if and how our particular B cell subpopulation is targeted by our strategies. And there are different papers that analyzed and tried to answer to this question. Here in lupus patient treated with rituximab, here the researcher, the authors showed how our B cell population changed over time after B cell depletion. Here in blue, we have the naive B cells, in red, the unswitched memory B cells, in green, gray, switched memory B cells, and here in green our double negative B cells, defined as IgD negative CD27. And you see that this actually increases in over time. And when they looked in detail to double negative, in the double negative area, here we see in gray our CD21 low CD11C positive B cells, and they reduces in percentages over time, for increase again at the end of the follow-up. So never completely absent after treatment. And in this paper, different authors analyzed the subpopulation of B cells after belimumab treatment, and they showed that these double negative B cells decreases over time, as we also showed, as in my first, at the beginning, we also had the same results after belimumab. But the group of Michael Cancro, which is a huge and a very important researcher focusing on these cells, his group showed in vitro in 2 mice model that these cells were minimally impacted by the treatment with anti-Bliss or CD20 target treatment. So this cell seems to resist to this B cell targeting cell treatment. And another important result comes from the CAR T cell treatment. Here, lupus patient treatment with the CD19 CAR T cell therapy, and here in red shown that they focused also on our B cell subpopulation, finding a significant reduction after treatment. So, if our canonical B cell depleting treatment seems, or we are not sure if they are effectively targeting our cells, and in thinking about more target treatment, we have to suggest and hypothesize new treatment strategy. And here is again, oops. here we have again our pathway involved in the differentiation of Tibet positive B cells. And as we saw before, the crucial is the role of IL-21 and interferon gamma together with IL-12, BAF, and CD40, and with the help of toll-like receptor 7 and 9. These all increases Tibet expression, whereas IL-4 serves as a repressor of this transcription function. So having this in mind, our some different suggestions are now analyzed from different groups. And starting here, we have that binding of IL-12 to the IL-12 receptors lead to the phosphorylation of STAT4 by these two kinases, and phosphorylated STAT4 enters the nucleus, initiate the transcription factors of gene, and these are all associated with the development of with the biology of double negative B cells, such as interferon gamma and IL-21. So JAK inhibitors like baricitinib, which is a JAK1/2 inhibitor, has been tested in vitro and has a role and affects double negative percentages, whereas ustekinumab has not been tested in vitro, but might be another strategy. And then we have another group that in this paper, which has a huge amount of very interesting data about CD11C positive B cells. I just want to show you that authors also showed that in patients with rheumatoid arthritis treated with JAK inhibitors, the percentages of double negative B cells reduced after treatment. And a researcher working on multiple sclerosis, they found that BTK inhibition was helpful in vitro to reduce the differentiation of naive B cells in Tibet positive B cells, reducing even the production of autoantibody. And another interesting findings talking again on possible therapeutic strategies comes from the groups that analyze the adenosine receptor 2, which is found increase in CD11C Tibet positive B cells. And this group in mice showed that using an agonist of these receptors reduced significantly these cells, and again the production of autoantibodies in lupus-prone mice. And another interesting findings is that these cells have a hypermetabolic state with an enhanced glycolytic capacity. This was shown even before this paper. But this group showed that glycolysis restriction impaired the formation of double negative of CD21 low B cells, and therefore the administration of glycolysis inhibitors ameliorated the accumulation of the cells, and again the autoantibody production in lupus prone models. And finally, this is just another suggested possibility to target these cells with engineered gold nanoparticles that were shown to target age-associated B cells, reducing their biology. And so, in conclusion, and now this is really my last slide. In conclusion, we have this relatively new B cell subset characterized by the expression of Tibet, CD11C, and the absence of CD21 low. We don't know if these cells are really helpful in health or more in disease, and how we can really target these cells. We have still many open questions about the real function, about the function in the inflamed tissue, and how to exactly target these cells, and finally, if these cells are really pathogenic or they have a protective potential. And taking the word from two teachers about this population, Stuart Tanguy and Michael Cancro, that indeed say that there are multiple subsets of CD11C for sure, and at different stages of differentiation. And taking the word of Michael Cancro, we can say that Tibet have emerged as a unique population that plays both protective and pathogenic role, thereby making it an attractive tool to manipulate immune responses in the desired direction. This is very interesting. And so we need further studies on these B cells to understand their real nature and function of Tibet positive B cells. So I would like now to finish my presentation and to thank you all for your attention.
Okay. Thank you, Marcella, for sharing your pioneering studies. This was a whole great sum of information that needed to be digested and assimilated. Thank you for presenting it to us in this elegant way. Thank you very much. Hope to see you again.
Thank you. Thank you.
Now we don't have time. We have to move to the last presentation. Is Dr. Che with us now? Okay. Hey, Dr. Evelyn Che.
Hi.
Hi, how are you?
Good. How are you?
Okay, let me present you at first. Dr. Evelyn Che is bound to present an update on osteoporosis. Dr. Evelyn Che is Associate Professor of Medicine, Rheumatology and Epidemiology for the chronic diseases at the Yale School of Medicine and Public Health in the USA. She is Chief of the Rheumatology for the VA Connecticut Healthcare System. She is dedicated to global rheumatological training and research. She focuses on the impact of chronic infection and inflammatory diseases on musculoskeletal outcomes, like osteoporosis, sarcopenia, and fracture risk. Her research combines biomedical and behavioral approaches. She delves into national cohorts and international registries to dissect drivers of risk for these outcomes. She got support by the NIH Rheumatology Research Foundation, CMB Foundation, and the Davis Duke Charitable Foundation. She was the founding chair of the ACR Global Engagement Committee from 2020 to 2023, affiliated to the ACR, or the American College of Rheumatology. She also co-founded the Yale Network for Global Non-Communicable Diseases. I have a very long list that I cannot finish now, so that the stage is yours to update us on osteoporosis, one of your favorite topics.
Thank you so much.
Thank you.
Thank you for the kind introduction and the invitation to present at your meeting today. Let me see if, do the slides look right?
Yes, it's perfect.
Great. Yes, so it's wonderful to speak to the Egyptian Society of Rheumatology and Clinical Immunology today, and to review a topic that is, one that I'm always enthusiastic about, which is osteoporosis. We're going to do a very brief review of drivers of osteoporosis. I'm going to focus on rheumatoid arthritis and glucocorticoid-induced osteoporosis today. And then we're going to switch gears and talk about risk reduction strategies for osteoporosis and fracture, current topics of clinical interest in the field, and finish with some remaining challenges and gaps. I'm just going to set my timer so I keep an eye on the time. So osteoporosis is a condition characterized by decreased bone mass, microarchitectural disruption, and skeletal fragility. And these can lead to trabecular thinning of the bone, increased porosity, microperforations, all of which accumulate in decreased strength and increased risk for fracture. These are some of the most common sites of fracture that we see in the clinic, but other sites can be involved as well. And why does it matter? Osteoporotic fractures can lead to significant morbidity, mortality, and economic impact for our patients and societies. And this is just one figure illustrating the impact of hip fracture on patients. Approximately 60% do not fully regain pre-fracture function and independence, and 20% require long-term care, which is quite important to patients in terms of quality of life. So I'm just going to review in a few slides some biology, but we have a lot to cover, so I won't go into detail, but I wanted to introduce a few key concepts which will help to talk about the clinical points later. So this is the bone remodeling cycle. Bone is a very dynamic organ that is constantly undergoing renewal at what we call the bone remodeling unit. And you can see here there are a few key players involved. The hematopoietic stem cells elaborate osteoclasts, which are the main bone resorbing cells. These go to sites of damaged or weakened bone and start to resorb those and clear those out, forming these resorption pits. These are the osteoclasts. And then osteoblasts, which are mesenchymal in lineage, come in, and these are primary bone forming cells, our primary bone formation cells. And these fill in the resorption pits with collagen matrix and bone, osteoid. And some of these osteoblasts become osteocytes, which become entombed in this matrix and play an important role in communication and signaling. And this process of resorption and formation are closely coupled under normal circumstances. And as I mentioned before, is a constant state that our bones are undergoing. And it's when those processes become uncoupled that we have some problems that can lead to osteoporosis and fracture risk. And I mentioned some of the signaling and crosstalk. We won't go into detail again here, but this is just another figure showing how osteoblasts and osteoclasts closely communicate. And a lot of that communication is importantly mediated through rank ligand, which can stimulate osteoclasts, and osteoprotegerin, which blocks that signaling. And that ratio of rank ligand and osteoprotegerin plays a key role in the ultimate balance of bone formation and resorption. So in rheumatoid arthritis, we have several impacts that are occurring that affect the skeleton, and that includes local bone destruction in the form of erosions, which is where occurring at the joint margins, where inflamed synovium interacts with the bone and can lead to bone destruction. Even in the setting of well-controlled disease, those do not heal for the most part, those erosions. We also have periarticular bone loss, which occurs at neighboring joints from all of that local inflammation. And then those inflammatory cytokines can go systemically and lead to systemic bone loss and increased risk for fracture. And so this illustrates the RA joint, what's happening at the RA joint relative to the normal joint. And just wanted to point out three things here, which is one, that the cells themselves, the synovial fibroblasts and lymphocytes that are at the site of inflammation themselves can elaborate and increase rank ligand, which again stimulates osteoclast activity. Also, the inflammatory cytokines that are in this milieu can drive increased bone resorption. And then the autoantibodies themselves can play a role. And this is seen in studies that have shown that even in the preclinical stage where patients may have autoantibody, but not clinical inflammation yet, there can be evidence that there is increased risk of bone loss, and that is because the ACVAs themselves can trigger osteoclast activation. In terms of glucocorticoid-induced osteoporosis, glucocorticoids are an important independent risk factor for fracture. About 10% of patients on long-term glucocorticoids are diagnosed with a clinical fracture, but many more have subclinical vertebral fractures that are detectable on X-ray. In the endogenous normal environment, glucocorticoids can play an important role in maintaining bone formation and organization. In the normal endogenous exposure, mesenchymal stem cells are favored towards an osteoblast lineage, as opposed to the other cells that it may produce adipocytes and chondrocytes. Whereas in the setting of glucocorticoid excess from exogenous administration, osteoblasts and osteocytes are major target cells for the glucocorticoids, and can both undergo apoptosis, which impacts that communication I was mentioning earlier. And also, this can decrease differentiation, proliferation, and function of bone formation. And the osteoblasts are important for regulating or producing osteoprotegerin. So as that goes down and rank ligand increases, that balance is disrupted and it favors osteoclast differentiation and activation. So you both have a dampening down of the bone formation and a ramping up of the bone resorption processes going on, and then a favoring of differentiation of the hematopoietic stem cells towards, the mesenchymal stem cells towards the other cell types. So the rate of bone loss is greatest within the first 3 to 6 months of glucocorticoid therapy, and this increase in fracture risk is out of proportion to declines in bone mineral density itself. And this is because it is not just the bone cells themselves that are affected, but as we all know from clinical experience, muscle atrophy and weakness occur, increased risk of falls, and that all contributes to higher risk for fracture, as well as impaired quality of bone. Both high daily and cumulative glucocorticoid doses increase risk of fracture, and this bone loss is reversible upon discontinuation of steroids. So now I'm going to switch gears and start talking more in the clinical management sphere. We're going to start with just an overview of the approach to fracture risk reduction. And the keys are to develop an appropriate case finding and screening strategy, optimize some of the non-pharmacologic intervention aspects, which may include optimizing the underlying disease, minimizing glucocorticoid exposure, promoting lifestyle and environmental modification, and also then considering pharmacologic intervention. And by that, I mean osteoporosis drug therapy when it is appropriate and indicated. So in terms of case finding strategies, the fracture risk assessment tool, there are other tools out there which look at clinical risk factors and help predict risk for fracture, but the FRAX tool is probably the most widely validated and used. It predicts 10-year probability of a hip or major osteoporotic fracture, taking into account 11 risk factors, and if available, femoral neck bone mineral density, and it calculates country-specific cost-effective thresholds for pharmacologic treatment that are based on the data from those countries that it has an option for. And Egypt is one of those, as you can see here, so you can calculate country-specific risk levels. So that's clinical risk factor assessment. Bone mineral density assessment is also important. There are different modalities for assessing bone mineral density. I will touch mainly upon DEXA, dual energy X-ray absorptiometry, because it is a gold standard used in epidemiologic studies and clinical trials. This can be used to diagnose osteoporosis and osteopenia formally. It allows direct measurement of bone mineral density at common sites of fracture risk, namely the spine and the hip, and also the radius, if you want to order that. And the important key thing about DEXA is you can also, so the benefit is you can monitor changes with therapy over time, or changes without therapy over time. But the key thing is to make sure you're using the same DEXA machine or have it cross-calibrated so that you can really actually compare the measures. And this is just an example of what the report looks like. There are, in other settings, ultrasound based DEXA measures or peripheral bone mineral density measures, which if those are the only available, they can be helpful as a screening tool, but it doesn't quite have all of the diagnostic attributes available. The other thing that is coming down the pipeline is utilizing other modalities such as CAT scan. So CAT scan, we've always been able to use CAT scan to look at volumetric bone mineral density, but now there are studies looking at AI techniques to be able to capture that on the opportunistically. So we'll see what the future holds for that. But for now, practically speaking, DEXA is, if available, is probably the most widely useful approach to measuring bone mineral density. And as I mentioned, and I won't go through in detail because I think this audience is quite familiar with DEXA, you can then have these with the T-score for postmenopausal women and older men. You can have these measures to define categories of risk and osteoporosis. And for premenopausal women and men younger than 50, you can get a Z-score to tell you if the person's bone mineral density is below the expected range for age or within the expected range of age. For the younger patients, we do not formally categorize them as osteoporosis or osteopenia, for example. So I'm going to highlight, and you'll see throughout the talk, I have a few highlights that are shown in yellow. And so trabecular bone score, it's not new per se. It's been around for about 10 years, and it's increasingly integrated into clinical practice. Here at Yale, we just started in the last 2 to 3 years, officially reporting it with all of our DEXA scan reports. It is what they call a gray level textural metric related to bone microarchitecture. What does that mean? So if you take these two examples, these are patients who had bone mineral density that were similar in range, in terms of what the bone mineral density was, but the bone was like this in one patient, which was well-structured trabecular bone, and in the other patient, it was like this. So areas where it may have been stronger, areas where there were perforations and pores. And so if you look at it on this, if they kind of extrapolate a variogram that shows that kind of density distribution, you can see one looks like this, which is nice and even, and the other has a lot of spots where it's, has missing bone. And so TBS can capture that difference and provide you with a TBS score. And a higher score means better quality bone, and a lower score means at degraded or partially degraded bone. And so this tool can be a very helpful adjunct to a bone mineral density report because in many circumstances, and glucocorticoid-induced osteoporosis is one of them, the bone mineral density report itself may not provide the full information of your patient's fracture risk. And so in this study, you can see these were patients who were exposed to glucocorticoids, some who had fractures, some who did not, and a control group. And if you look just at bone mineral density, there was not necessarily a significant difference between groups, but looking at trabecular bone score, you could start to see that significant difference by TBS between the groups. And so for our patients, that may be a very helpful tool to include. And vertebral fracture screening, either with the VFA, vertebral fracture assessment feature of a DEXA machine, or a lateral thoracolumbar X-ray, which is actually better quality but less convenient because you can't get it at the same time as DEXA, can help you identify fractures which may not be presenting clinically. And these are just the indications for when to get a vertebral vertebral image to look for fracture. And the key takeaway I will say here is to pay attention to height after your patients are over 50, to measure it every few years to make sure that they're not having height loss, which might be an indication that they're having subclinical vertebral fractures. Certainly if they have ongoing glucocorticoid therapy or other conditions that are known to be associated with bone loss, such as RA, it would be an indication to screen. Another important case finding strategy that I can't emphasize enough is secondary fracture prevention and the use of fracture liaison services to identify patients who would be at risk for future fracture, because a past fracture is potentially the greatest driver of a future fracture. And unfortunately, less than 35% of patients with a hip fracture go on to receive pharmacologic therapy within 6 months. And so the goal of fracture liaison services is to identify patients in the peri-hospitalization period and link them to a multidisciplinary osteoporosis care team. The Egypt Academy of Bone Health does have a fracture liaison service program that is outlined, and so I think that is a wonderful resource to turn to think about how your centers may develop this type of program as well. Highly effective in identifying patients at highest risk for fracture, but it is also incredibly cost effective as well, because you're preventing those future hospitalizations and surgeries related to fracture. And speaking of surgery, I'm going to highlight another area which is more recently been emphasized, which is that patients with osteoporosis or prior fractures are at increased risk for skeletal complications during and following orthopedic surgery. And so this can include more risk of fracture after or during surgery as well. And this can be related to hardware motion or failure in the setting of osteoporotic bone. It is very rare for bone health screening to occur in that perioperative setting, but certainly for elective orthopedic surgeries, this is a opportunity to really enhance bone care. Just keep in mind the caveat that if you are doing a DEXA scan prior to surgery, if the patient has a lot of degenerative disease, osteophytes, that might artificially elevate your lumbar spine reading. And so you want to pay attention to that and potential vertebrae that maybe shouldn't be included in the calculation of the lumbar spine bone mineral density. You may consider perioperative pharmacology for bone quality, and those that have been studied include teriparatide for spinal fusion, bisphosphonates for arthroplasty, but the data are very limited, and this is just a very recent area that is gaining more attention. Just this year, 7 national societies came together, orthopedic trauma and osteoporosis societies came together and developed this joint position statement that offers some guidance on this. So in terms of risk reduction strategies, there are a lot of approaches. Lifestyle modification is always important and so accessible. Of course, it is hard to motivate patients to make lifestyle change, but it is something that at every encounter with patients, we have the opportunity to move forward with and is non-invasive. And also improves their health in many other domains besides bone health. And so I think that is something we can really underscore as well. So of course, smoking cessation and alcohol reduction, dietary and exercise changes. And when it comes to exercise, weight bearing, resistance training, and balance training are the key areas to emphasize. And fall risk reduction, because fractures are the result of a combination of bone fragility and increased falls. And these are some key areas that pay attention to in terms of assessing risk for fall and talking to your patients about preventing falls, assessing recent falls, physical function, and there's many tools that can be used to assess physical function, cognitive status, polypharmacy and multimorbidity, sarcopenia, and frailty. These are all really important to consider in terms of your patient's fall risk. In terms of calcium and vitamin D intake, what I read was the Egyptian Society's recommendations are 1 gram of calcium daily and 1,000 international units of vitamin D daily for adults. And so there are different ways, the dietary route is always the best, or sunlight exposure. So these would be ideal because you don't worry about potential impacts of taking more medications, more supplements, and leading to polypharmacy or other potential side effects or intolerances. So you can work with patients with a simple tool that helps them quantify their calcium intake on average in a day. Can talk with them about sunlight exposure for vitamin D and foods. Routine screening is not indicated for everyone, but for our patients who maybe have rheumatoid arthritis or glucocorticoid use, it would be reasonable to check and try to make sure their vitamin D is at goal. The vitamin D vital study that was published a few years ago was a randomized control trial of supplemental vitamin D and omega-3 fatty acids, or both. And their primary outcome of interest looked at cancer and cardiovascular disease, but they had an ancillary study that examined supplemental vitamin D and whether or not it conferred a lower risk of incident fractures compared with placebo. So the short story is it did not find a difference between the groups. And the key caveat for us, though, because we take care of a special group of patients, is that these patients were not selected for having higher risk per se of osteoporosis or fracture. They were generally healthy and did not have low vitamin D or low bone mass or osteoporosis at baseline. So, I think this supports prior, recent data coming out showing that in the general community, healthy patients, there's not specifically a role for supplementation. However, in our patients who do have high risk, it is part of a overall approach towards bone health. Adequate protein intake is important as well. Is there a question?
Sorry for the interruption.
Okay. And then in terms of exercise, high intensity resistance and impact training is an area that is increasing attention over the years. This is one study that was very pivotal in the high intensity resistant training literature. And it showed that a supervised exercise regimen with high intensity compared to a standard exercise regimen could both increase bone mineral density here in the dark gray bars, as well as functional status. And these are, again, in the dark gray bars, different various tests of physical function. And a meta-analysis later that looked across multiple studies showed that intensity and supervision matter. So in a group of studies where exercise was not supervised, they did not find an effect. There was not a protective effect. But in those that had supervised exercise, high intensity exercise regimens, there was a favorable protective effect. And again, the bone mineral density change also occurred in the high intensity group as opposed to low and moderate intensity. So intensity and supervision do drive the benefits in this case. And this is the ACR had published in 2022 its latest GEOP guidelines. And I'm going to just mention it here because when we have our patients who are starting glucocorticoids, thinking about how to screen for their fracture risk is important. But don't worry too much about the numbers because different societies have different specific thresholds. So here for the ACR, it was anyone who's on 2.5 milligrams per day or more for 3 months. The European guidelines do not have a specific number. They just say anyone who's initiating glucocorticoids, and this specific age is a little bit different guideline to guideline too. So again, the key take-home message here is that if your patient is on chronic glucocorticoids of a certain dose or any dose, to start thinking about which category, how you can screen them with clinical risk factors for risk, and then which category of risk they might fall into, and if you should obtain a DEXA scan. If you use FRAX, there is a correction where, depending on the dose of an exposure of glucocorticoids, you might increase you might do a multiplication to adjust for the amount of glucocorticoids being taken. And then again, after initiation and follow-up, it's also important to think again about what their changing risk is. And there is guidance also for those who decide to start therapy because they're high risk or very high risk, and moderate risk decided to start therapy. You would monitor and consider what you want to do with the therapy over time. And for those who do not decide to go on therapy because they're either low risk or moderate risk but don't want to start therapy, you would continue to monitor and continue to have that discussion about when it might be appropriate to start therapy. Okay, so in the last section, in the last 10 minutes or so, we're just going to go through the different pharmacologic therapies. And it's going to feel like a lot, but we'll just try to summarize. I'll try to summarize briefly the different therapies so that we can put it all together. And so now this is an example, again, of once your patient should be on medication, how you might think about it and separating patients into very high risk, or moderate risk, or low risk. So to talk about the treatments, we have anti-resorptive and anabolic, so those that prevent absorption through the osteoclast activity, or those that focus on bone building through the bone building osteoblasts. Bisphosphonates are going to be our most common class, and those you have to be careful of renal function and some of these other characteristics in terms of prescribing them. But overall, they are effective for the most part, at the vertebra, at the hip, except for abandronate, which was only shown for vertebra, and they can be taken orally or intravenously. They have been shown in multiple studies to increase bone mineral density, specifically in RA and glucocorticoid-induced osteoporosis, and for some of them to decrease vertebral fractures. Given the long duration of storage in bone, when you are talking to premenopausal women who may become pregnant, having a shared decision-making conversation about the potential risks is important, although more and more studies are showing that its use in premenopausal women can be safe. I'm just going to highlight 2 key adverse effects that get a lot of attention, and that's osteocrosis of the jaw, which is very rare, but can be seen particularly in patients receiving high-dose zoledronic acid for cancer, but has been seen in other anti-resorptives too. So I need to mention it. And the key is that those who need to be on therapy should have close oral examinations, and any plans that do come up later for dental surgery, then their medication should be held temporarily. That being said, there's no clear evidence. It's just a clinical guidance over time that has been followed. So more data, more research is needed on that. But it's difficult because the numbers are small. Atypical femoral fractures also are a rare event, but can be very distressing and disruptive for patients. It is a simple transverse or oblique fracture that occurs. You can see this early cortical beaking and cortical thickening in a prodromal period. They might have some thigh pain, and it can be linked to long-term bisphosphonate use. So now duration of bisphosphonate use is carefully considered. It can be associated with corticosteroid use, anti-resorptive drugs, and proton pump inhibitors, and can occur at both sides. So now, after 5 years of an oral bisphosphonate or 3 years of zoledronic acid, there is sort of a pause to consider whether the patient should continue or not on the bisphosphonate therapy, or if they should take a holiday. And if the patient does have a very high risk, then it is reasonable to continue, because ultimately, at the end of the day, the benefit from preventing a hip fracture outweighs the potential risk for developing these atypical fractures. So it's important to continue if it's needed. But for those who are doing well and have, are stable, it is reasonable to reduce unnecessary exposure. So moving on, denosumab is a fully human monoclonal antibody to rank ligand, which we talked about before. Rank ligand is important for activating osteoclast. So the inhibition then can block that osteoclast activity. It can be used in patients with compromised renal function. So that's one of its benefits. And it's been shown to have benefit for at least 10 years. In patients with RA or on glucocorticoids, the alendronate has been, denosumab has been superior to alendronate, both at the lumbar spine in the top panels here and total hip in the top panels, in the bottom panels here. So you can see it's superior, both in those who are initiating glucocorticoids and those who are continuing glucocorticoids, who are on long-term glucocorticoids. And concerns of infection have arisen, particularly for our patients on concurrent TNF inhibitors. But this study by Curtis and colleagues showed that it did not appear to be a higher rate of infection. So that's reassuring. One important problem with denosumab is that when you stop the therapy, that benefit is rapidly reversed. And so for patients who are finishing therapy, if you don't put them on another medication, they can develop increased vertebral fractures. And therefore, you need to bridge them with something else, such as a bisphosphonate. It does also have the risk for atypical femoral fractures and ONJ, and it is not recommended in pregnancy. Estrogen and SERMs are the other group of anti-resorptives. So menopausal hormone therapy, for a while, use really declined after the initial publication of the Women's Health Initiative trials because of a signal that it increased risk for cardiovascular events, stroke, and venous thromboembolism. Later studies, however, showed that initiation within 10 years of the final menstrual period, so early postmenopause, and age less than 60 years, actually was associated with a favorable benefit risk balance. The key is that the benefits last only as long as the therapy continues. And so similarly to denosumab, you need to bridge patients to another therapy if they still have risk for osteoporosis, but you do not have that increase in fracture rate that we saw with denosumab. And the rapid bone loss with estrogen, yes, can be mitigated with the bisphosphonate therapy. For SERMs, the important thing to note is that this is really for postmenopausal women because that bit of estrogen activity improves bone mineral density and decreases fractures, whereas in premenopausal women who have their endogenous estrogen, this can actually be inhibitory and cause the opposite effect on bone. It's not as potent as bisphosphonates, and have not been shown to decrease non-vertebral hip fractures, but it is a good alternative for women who can't take bisphosphonates or at high risk for invasive breast cancer, since it is used as part of adjuvant breast cancer therapy. In GEOP specifically, it's been shown to increase bone mineral density. However, there haven't been clear studies demonstrating fracture benefit. So for PTH receptor agonists, we have two, teriparatide and abaloparatide. And the idea behind this is that intermittent parathyroid hormone stimulation increases bone remodeling with formation outrate resorption, whereas compared to continuous PTH exposure in hyperparathyroidism, for example, that actually is detrimental, and for bone, intermittent stimulation is beneficial. And so these are studies showing that in patients on glucocorticoids, teriparatide is superior at the lumbar spine, total hip, and femoral neck. And this was a meta-analysis of studies that were able to collect fracture outcomes, and it showed a benefit for vertebral fractures as well in GEOP. It is conditionally recommended for those who are very high fracture risk because of its anabolic effect, and potentially those who are on moderate or just higher risk, but not very high risk, depending on the clinical decision making. It's also an option for premenopausal women because it has a short half-life. You just want to make sure the epiphyses are fully fused to avoid risk of osteosarcoma. And the drawbacks are it is a daily subcutaneous injection and it is expensive, so it's not accessible to everyone or tolerable in everyone. And as I mentioned, there was this concern for increased osteosarcoma incidence in rats. However, recently the 2-year restriction has been revised in the US based upon post-marketing data that showed no increase in human osteosarcoma rates. So that experience has been helpful. And finally, romosozumab is the newest agent on the block. This is an anabolic agent that inhibits sclerostin. Sclerostin naturally binds the Wnt pathway, which is important in osteoblast formation. So when you block sclerostin, you open up that pathway and promote osteoblast formation and activity. And the impressive thing about romosozumab is that it both increased bone formation here right after treatment is initiated. These are bone formation markers, but it also decreased bone resorption marker. And so it's kind of got this dual effect, which makes it particularly potent. And so you can see compared to, this is Romo in the green, compared to teriparatide or alendronate, it's got really strong efficacy at lumbar spine, total hip, and femoral neck, and also decreases fracture rates. There is a black box warning, however, because of increased cardiovascular events in one of the trials of romosozumab compared to placebo. And so you must avoid in patients with MI or stroke in the past year. It's only effective for 1 year. When you give the treatment, that effect only lasts for 1 year, so that's the duration of treatment. In RA, there have been just a few studies that have come out that do show that, particularly at the lumbar spine, it seems to have a benefit And in glucocorticoids as well, it showed a benefit of in terms of bone mineral density at the lumbar spine. And so finally, sequential therapy principles. Bone loss occurs at varying rates when osteoporosis medications are stopped, in general. So this is a table showing for the different agents we've discussed what happens. And therefore, for example, stopping denosumab can be accomplished safely, but you need to transition to an adequate bisphosphonate regimen. And it's important to note here that if you transition to something like teriparatide, it actually exacerbates the rebound in the bone resorption markers and bone mineral density decline. So you don't want to do denosumab to teriparatide. Switching from bisphosphonates after after your treatment with bisphosphonates, if it's not working or there's not tolerated anymore and you want to switch to denosumab or romosozumab, this does lead to further improvement in bone mineral density. However, again, when you switch from bisphosphonate to teriparatide, you see a blunted anabolic response. So anti-resorptive to an anabolic doesn't seem to work so well, except with the romosozumab, that's okay. So in general, that combination of treating first with the osteoanabolic in those very high-risk patients, followed by anti-resorptive agents, that does get you substantial gains. And so that's why in these new treat to target approaches or goal-directed therapy approaches, identifying those patients who are at very high risk or imminent risk of fracture is now important because you have an option for treatment that uses an osteoanabolic first, followed by an anti-resorptive to really reduce rapidly the fracture risk. And so this was the last highlight I wanted to show. And I think my next slide is actually, yes, the Egyptian guidelines. Here you can see actually in 2021, the Egyptian Society had published guidelines and we're already adopting a treat to target approach where the very high risk group is emphasized and so that they can quickly get treatment with an osteoanabolic, but then also looking at the other groups and identifying what are the appropriate goals and how to treat them. Great. So some remaining challenges and gaps. There are few trials among patients with RA and glucocorticoid-induced osteoporosis that are powered for fracture endpoints. So we still need more data to confirm that the BMD gains are supported by future fracture reductions. There's a lot of nuance regarding osteoporosis treatment holidays that still require clarification, and data are really mostly in postmenopausal women right now and not in other groups. This new area of perioperative assessment and management, we don't really know yet how we can optimize that for patients with RA and glucocorticoid-induced osteoporosis. And there's still a lot that's unknown about ideal strategies for management in premenopausal women. And so more work is needed there. And finally, can the goal-directed therapy approaches be directly translated for glucocorticoid-induced osteoporosis? I think at this point we extrapolate that it can, but again, further research will confirm that, hopefully, or at least tell us how it needs to be adapted. So inflammatory diseases such as RA are strongly linked with bone fragility due to immunologic drivers of osteoclast activity. Glucocorticoids independently and rapidly increase fracture risk, but this effect is reversible. Timely prevention, screening, and management is critical and achievable. There have been many advances in recommendations regarding sequential therapy, which is needed after denosumab, teriparatide, and romosozumab. And more data is needed regarding the impact of these therapy on fracture outcomes in patients with RA and glucocorticoid-induced osteoporosis. Thank you so much. I'm so sorry. I know I went over. Like I said, I just get really, there's so much good information on this topic, and I wanted to make sure to share it.
Thank you very much, Dr. Chi. Do you have questions? Yes, we have one.
Thanks, Doctor, for interesting and concise lecture. I'd like to ask about the use of bisphosphonate or other osteoporotic treatment in a childbearing period, and if delivery occur.
I'm
If
sorry,
pregnancy, sorry,
hear,
if pregnancy occurs, sorry.
Might you repeat that? I couldn't hear very carefully which agent you meant.
Bisphosphonate?
Bisphosphonate.
Yes. And what about bisphosphonates?
Bisphosphonate use in a childbearing period.
Oh, in the childbearing period.
Young female patient
Yeah.
with steroid and pregnancy can occur.
Yeah. Yes, I think that the childbearing period is so challenging, but at the moment, bisphosphonates are considered a choice for women of childbearing age. It's recognized that because it binds to the hydroxyapatite, it stays in the system for a very long time, and I think that has driven most of the concerns about what effects that might have, you know, on the fetus later on. However, it seems over time that that has not borne out consistently. And so now it is recommended, but still, I think we're all very cautious and still, you know, focus on having shared decision making, you know, of course, for patients who are actively fracturing. So I will just take a step back and say that for younger patients, their age is such a natural protective factor. So if they are not actively fracturing, you know, then monitoring, even if their bone mineral density is low, monitoring, counseling, you know, other adjunctive ways to help build their bone health through the other non-pharmacologic methods is really important. But if they are fracturing and repeatedly fracturing, then clearly they need pharmacologic therapy. So it's really a discussion with the patient in terms of when to initiate therapy, because they might, even if their bone mineral density is quite low, they might actually stay fracture free over time until they can be off of the steroids. That being said, if they really are at imminent risk or are, you know, already fracturing, and we need to treat with something. So bisphosphonates and teriparatide are the main options, recognizing that teriparatide, you know, maybe you have a bit more than 2 years because now we're loosening up that guideline, but you know, I think there's still a question mark of how long you could be on it. And bisphosphonates, I think the experience is showing over time that it's probably a safe treatment. And we just really need more research in this area, unfortunately. And there's no, you know, data for romosozumab, for example. And so I think as we go forward, hopefully there will be more studies in this area.
Any more questions? May I ask you just one question, Dr.
Sure.
Che? It is said that a combination of teriparatide with denosumab is good, they work together. How, and the sequential part of it is not recommended. How about starting with the denosumab and then after a while adding, after several months, adding teriparatide?
So unfortunately, it seems that if you start with a bisphosphonate or denosumab, and then you switch to teriparatide, it actually has a, you know, a blunting effect or increase of resorption. So it's unfortunately not a good sequence to start with denosumab or bisphosphonate and then go to teriparatide. Unlike the opposite, when you start with teriparatide and then switch to either denosumab or bisphosphonate, that works quite well and gives you a lot of benefit.
I mean, how
Yeah,
about
it's
the
kind of
combination?
surprising, but yeah, neither of those.
I meant the combination, keeping the combination.
Oh, you mean keeping the combination, keeping them both on at the same time?
Yeah.
Yes. So,
Like
you know, I
add-on.
did. Yeah. So I would have to get back to you on that. I did previously have that, but I don't want to misspeak because there are some nuances to the combination also. And, you know, I don't want to misspeak in terms of like, what is that nuance? So let me get back to you on that because I think it is also an important point. And I'm glad you brought it up, actually.
Thank you very much. We are pleased
Thank
and
you.
honored by your contribution and by your very remarkable presentation. We come to the end of our review course and hope to see you again in one of our meetings and looking forward to seeing you soon.
Same
Okay,
here.
thank you
Same here.
again.
Thank you so much.
Thank you.
Have a wonderful day.
You
Bye.
too. Bye-bye. By this, we come to the end of our review course and the end of first day of our meeting. Thank you for bearing with us. أتكلم عربي بقى.